Good morning, everyone. I'm Raghav. Thank you for the introduction, Michael. And it's a great privilege to be able to stand here at the first CRY conference since the pandemic as a face-to-face conference. So thank you very much. I'll be hopefully unveiling some novel insights, and overall my talk will address sudden cardiac death in young individuals. And I'll be focusing in particularly on what can we glean from the Office for National Statistics and data relating to young individuals. Now we know that the accurate representation of the incidence and etiology of sudden death in young individuals is critical, particularly for healthcare policymakers in allocating resource allocations. And of course, we know data that stemmed from CRY almost 2 decades ago now, that the incidence of sudden death in young individuals in England and Wales particularly has been quoted to be around 1.8 per 100,000 individuals per year if we look at ONS data particularly. Extrapolations from that data set provided an estimate of around 12 deaths per week occurring in young individuals in England and Wales. This study essentially builds upon work that has been previously published through CRY and through Professor Papadakis and team. So the aim of my study was to investigate the incidence and causes of cardiac and sudden death in young individuals, i.e. those under the age of 35, within a 21-year period, which included 2001 to 2021. And in addition, for the first time, we wanted to establish any temporal trends in mortality, which has not been previously reported upon. So what did we do? Well, we looked at mortality data from the Office for National Statistics between this 21-year period and analysed it according to the year, the gender, their age, and the cause of death. Particularly, we focused in on ICD-10 classification codes, which were considered to represent cardiac and sudden cardiac death in this cohort, and this was developed with 5 experts in the field. We then categorized these ICD-10 codings into 4 different groups. Most importantly, Class A1. These include individuals where the post-mortem was normal. And in essence, these deaths are compatible with sudden arrhythmic death syndrome, or termed SADS, as you heard this morning. Category A2 were definite cardiac deaths with a structurally abnormal heart. Class A3 were definite cardiac deaths with an indeterminate cause, and these deaths essentially allude to a mode of death, such as left ventricular failure, congestive heart failure, rather than exact pinpoint cause. And finally, Class B, and I'd like to really focus in on this group because it's very important. And these deaths represent possible cardiac deaths, which may represent misclassifications in mortality, particularly deaths such as drowning or epilepsy, which may in fact represent deaths attributed to SADS. So, due to the nature of the study, which covered data over 2 decades, we extrapolated mortality files from ONS using 2 different data extract technologies. And we merged our data sets and analyzed this meticulously for the purpose of this study. Particularly, we looked at medical certificates of causes of death, which is in accordance with the World Health Organization, and in particular, part 1 of the death certificates. So what did we find? Well, in the study period, if we focus in on everyone who died in Class A as an entirety, which is essentially all the definite cardiac deaths, we got a mean of around 414 deaths per annum. And if we use census data from the UK statistics, this correlates with an incidence of 1.67 per 100,000 individuals per annum. And in category B, which represents possible cardiac deaths, we estimate around 573 deaths occurring on an annual basis, which correlates with an incidence of 2.32 per 100,000 individuals per annum. Now, at this stage of my talk, I would just like to emphasize that as an estimate, if we take everyone who died from definite cardiac deaths and at least perhaps 20% of deaths that occurred in the possible cardiac deaths group, we approximate that in England and Wales, there were 10 young sudden cardiac deaths occurring on a weekly basis. In terms of the definite causes of cardiac deaths in young individuals, ischemic heart disease represents 28%, cardiomyopathies 26%, within which we see a DCM being the predominant cardiomyopathy, followed by cardiomyopathy unspecified, within which arrhythmogenic cardiomyopathy falls, followed by hypertrophic cardiomyopathy. And of course, sudden arrhythmic death syndrome is right up there as the third top cause, contributing to 22% of deaths. Further causes include myocarditis, valvular heart disease, hypertension. In terms of possible cardiac deaths, very briefly, I just wanted to highlight that epilepsy, drowning, and a group called other ill-defined and unspecified causes of mortality contribute to the majority of possible cardiac deaths, which of course, as we know from published literature, some of these deaths are actually attributed to primary electrical diseases, and perhaps might represent some misclassifications in ONS datasets. I would like to focus in on some temporal trends now, and I'm going to start with the cardiac deaths with an indeterminate cause. As you can see, over 21 years, we see a downward trajectory, and roughly this equated to a 4.5% reduction in the incidence over the study period. Next, structurally abnormal hearts. Similarly, in the 21-year period, we see a downward trend with a 2.5% reduction in the incidence per annum. Next up, sudden arrhythmic death syndrome. Quite strikingly, we see an upward trajectory. And nationally, this data sets show that the incidence really went up steeply from 2001 to 2021, with an 8% annual increment in the incidence with a statistically significant value. Thereafter, we do see an incline as well, but to a lesser extent at 0.6% per annum between 2010 to 2021. So I was particularly interested in looking at our data sets at Cardiac Risk in the Young and the Centre for Cardiac Pathology. I'm very grateful to Professor Shepherd and Dr. Westerby for sharing this data. And I really wanted to home in on what do we report as SADS, what are the numbers on an annual basis, and perhaps compare and draw some parallels with data from ONS. This bar chart, where in blue you have SADS deaths from the CRI-CCP, and in the red bars are ONS SADS correlations. And hopefully you can appreciate a similar upward trend in SADS mortality in the study period, most notably from 2001 right up to, say, 2011, 2012. But what really struck me was that there is a difference between what we report as SADS and what, in the end, might be quoted on a death certificate. And it's very important to appreciate that this discrepancy is because there are issues with the existing ICD-10 codings, whereby SADS did not have a well-defined ICD-10 code during a 20-year period. And this, of course, is going to change with the advent of ICD-11 codes, which are now coming into effect. What about definite cardiac deaths in its entirety? So just to recap, that's everyone in class A1, A2, A3. We see a similar downward trend in a 21-year period with a 1.3% reduction in the incidence rates per annum. Finally, I just wanted to concentrate on gender and age very briefly. The salient points are that definite cardiac deaths are more common in men with a ratio of 2.3 to 1. Possible cardiac deaths, again, are more common in men with a ratio of 1.7 to 1. And when we look at particular causes such as ischemic heart disease, myocarditis, and epilepsy, we found significant differences between men and women. But interestingly, we didn't find any significant differences based on our methodology between men and women who died from sudden arrhythmic death syndrome or from cardiomyopathies. What about age? Well, we divided our cohort into different age brackets, 0 to 9, 10 to 19, 20 to 29, and 30 to 34. I'm going to focus in on just 3 conditions for the purpose of time. Firstly, ischemic heart disease are depicted by purple. You can see that there is an increment in deaths attributed to ischemic heart disease. And this is particularly reflective in the 20 to 29 and most strikingly the 30 to 34-year age group. And that's very similar to data from other published studies, PM registries, as well as other death certificate-based registries. What about cardiomyopathies and SADS? Well, you can see depicted by yellow and blue. These are more common in individuals in the 10 to 19 age brackets and 20 to 29. But also to appreciate that deaths do occur in the other age ranges. But I just wanted to highlight that similar to other published literature, they really come in and are very common in the adolescent and in the 20 to 29-year age group. I'll be the first one to say that our study has some limitations. Firstly, our study lacks conclusive evidence whether individuals included in ONS mortality datasets died from known cardiac conditions. But we do know from data that we've published from the CRI-CCP that in up to 80% of young individuals who die suddenly, they often have a quiescent cardiomyopathy or an electrical issue which has not been manifested itself ante-mortem. And I think that's a very important point to remember. Our data obviously lacks information on ethnicity, physical activity, whether someone was an athlete or not, all of which we know from other literature are recognized factors in sudden death in young individuals. And finally, we're unable to provide detailed explanations as to why we're observing a decline in mortality in young individuals from a cardiac perspective. It's of course plausible that preventative strategies, including cardiac screening, medical therapy, enhanced sophisticated medical and surgical techniques, and perhaps even widely practiced CPR, and AEDs might be contributing to this reduction in mortality. So to conclude, compared to other population estimates, our incidence of definite cardiac and sudden death is around 1.67 per 100,000 individuals per annum. And this, I think, emphasizes potential misclassifications into other categories such as Class B, which may in fact represent definitive cardiac deaths. Headline message: ischemic heart disease, cardiomyopathies, and SADS are the top 3 causes of mortality in young individuals. The incidence of definite and possible cardiac deaths in young individuals has decreased over 21 years. And this, of course, may be due to preventative strategies which have been widely implemented, particularly in the last 2 decades, and certainly ties in with the work that we do with cardiac risk in the young. And finally, key message is that the burden of cardiac and sudden death in young individuals really underscores the need to expand and to continue with preventative strategies and targeted risk management. I'd like to finish by thanking the charity CRY, ONS, my colleagues, my supervisors who really supported this research. Thank you.